Hydrops fetalis refers to abnormal fluid collection in the fetal soft tissues and serous cavities. Its diagnosis requires the presence of 2 out of 4. These are ascites, pleural effusion, pericardial effusion, and skin edema. The presence of fluid in organs such as ventriculomegaly or the presence of polyhydramnios, although common, they are not part of the diagnosis. Hydrops fetalis may be immune or non-immune. Immune hydropsy is found in association with red cell alloimmunization, while non-immune comprises a subgroup of cases not caused by red cell alloimmunization. The prevalence of non-immune Hydrops fetalis ranges from 1 in 1,500 to 1 in 4,000 pairs. The widespread use of Rh immunoglobulin has dramatically decreased the prevalence of immune Hydrops fetalis. As a result, non-immune Hydrops fetalis now accounts for about 90% of all cases of hydrops. Fluid homeostasis within vascular and interstitial compartment is controlled by both hydrostatic and osmotic pressure within vascular and interstitial compartments. This regulation of the net fluid movements between vascular and interstitial spaces leads to non-immune Hydrops fetalis. It can be caused by one or more of the following features: obstructed lymphatic drainage in the thoracic and abdominal cavities, increased capillary permeability, increased hydrostatic pressure, or decreased osmotic pressure. Non-immune hydrops occurs due to many maternal and fetal causes. This includes aneuploidies such as monosomy X or trisomies, genetic syndromes, for example, arthrogryposis or myotonic dystrophy, infections, for example, parvovirus P19, TOG, listeria, fetal cardiovascular disease, fetal anemia, metabolic storage disorders, or thoracic disorders such as CCAM, CDH, pulmonary sequestration, primary hydrothorax. Mechanism of non-immune Hydrops fetalis differs according to the etiology. Fetal anemia, for example, will stimulate extramedullary hematopoiesis, which impair hepatic protein synthesis and consequently decrease plasma oncotic pressure. Volume overload due to increased venous return and heart failure increase hydrostatic pressure, and also it produces tissue hypoxia, which increase capillary permeability. Lymphatic abnormality is another cause. It will decrease lymphatic flow. All these factors will finally result in increased interstitial fluid and the development of Hydrops fetalis. A case of non-immune Hydrops fetalis may be discovered incidentally during routine antenatal ultrasounds, or during workup for decreased fetal activity, or during workup for uterine size greater than expected. Ask about ethnic background, personal history, and family history. It may identify heritable disorders associated with Hydrops, such as alpha thalassemia, metabolic disorders, and genetic syndromes. Ask about consanguinity, because this may increase the probability of recessive disorders. Ask about recent illness or infectious contacts, particularly exposure to infants with parvovirus P19. Obstetric history may reveal a previous history of non-immune Hydrops fetalis. Assess maternal status. Ask about discomfort, abdominal expansion, symptoms of preeclampsia. These manifestations may alert to the evolving polyhydramnios and maternal mirror syndrome. Ask about decreased fetal movements. Let's discuss in some details what is mirror syndrome. Mirror syndrome, also called Ballantine syndrome. It refers to a condition of generalized maternal edema, often with pulmonary involvement, that mirrors the edema of the hydropic fetus. I mean, the fetus is hydropic and the mother also is hydropic. The pathogenesis is unknown. However, it is suggested to be due to a systemic inflammatory response triggered by the hydropic placenta. Another suggested mechanism is the increased production of soluble FMS like tyrosine kinase, which is an important mediator associated with maternal endothelial and vascular abnormalities associated with preeclampsia. It presents with rapid weight gain, increasing peripheral edema, progressive shortness of breath, or it may present as a clinical picture of preeclampsia with severe features. To differentiate between mirror syndrome and severe preeclampsia, in mirror syndrome the hematocrit is often low due to hemodilution, while in preeclampsia there is hemoconcentration. There is often polyhydramnios in mirror syndrome, but oligohydramnios is expected with severe preeclampsia. In mirror syndrome, the fetus always shows signs of hydrops. However, with severe preeclampsia, the fetus is not hydropic. Regarding management of mirror syndrome, delivery is usually required to induce remission of maternal symptoms. Returning back to our assessment, during general examination, measure blood pressure and look for edema. Abdominal examination may reveal a size larger than expected due to polyhydramnios. Investigations include detailed ultrasound examination. This includes thorough assessment of the fetus, placenta, umbilical cord, and amniotic fluids. Diagnosis requires 2 out of 4, as we said. This includes ascites, pleural effusion, pericardial effusion, or skin edema. It also identifies major structural abnormalities, fetal cardiac arrhythmia, and twin-to-twin transfusion syndrome. These pictures illustrate the features of non-immune hydrops fetalis. In the first feature, this is a face profile. We can identify the skin edema. In picture B, we can see a coronal section. These are the lungs, and the stars demonstrate pleural effusion, while arrows refer to ascites. Around the heart, we can see pericardial effusion. And in the last image, we can see ascites. This is ascitic fluid, and the skin of the abdomen is thickened. The thickness 5 mm or more is diagnostic of skin edema. Another important use of ultrasound is measurement of middle cerebral artery peak systolic velocity to identify fetal anemia. Ultrasound also examines the placenta. Placental thickness more than 5 mm indicates placentomegaly. The placenta may have a ground glass appearance, and the placenta chorioangioma can cause non-immune hydrops fetalis. Laboratory investigations include complete blood picture with red cell indices, hemoglobin electrophoresis for carriers of hemoglobin variants, blood type and antibody screen for immune-mediated fetal anemia, to perform Kleihauer test or flow cytometry to exclude significant feto-maternal hemorrhage. Genetic testing for fetus with structural abnormality is indicated. Samples obtained for karyotyping include amniocentesis, chorionic villus sampling, or fetal blood sampling. Maternal serology is important to test for common infectious causes such as parvovirus B19, cytomegalovirus, especially if there is bilateral periventricular hyperechogenesis, toxoplasmosis, especially if there is intracranial hyperechogenic foci, and also to test for syphilis if it is not recently performed. Regarding management of non-immune Hydrops fetalis, termination of pregnancy is an option for cases with a lethal prognosis. Another option is fetal therapy. We have some treatable cases and other non-treatable causes. Treatable causes includes treatment of fetal arrhythmia. Tachyarrhythmia and bradyarrhythmia can lead to hydrops. Treatment of tachyarrhythmia with antiarrhythmic drugs, which may be given through maternal administration or through direct fetal therapy, may be necessary in case of hydrops. Fetal hyperthyroidism is another cause of fetal arrhythmia, and maternal treatment with antithyroid drugs can be effective. Regarding medications for fetal tachyarrhythmia, the first line is flecainide. If this is not effective, the second line is the addition of digoxin to flecainide. If not effective, the third line is digoxin and sotalol. Another treatable cause is fetal anemia. In utero transfusion may be performed for severe cases. However, delivery of the fetus may be necessary in certain situations. In cases of twin-to-twin transfusion syndrome, fetoscopic laser ablation is the treatment of choice. The goal of treatment is to disrupt the placental circulation and restore balance between the twins. This table contains a variety of treatment options for fetal conditions. Few of them are treatable. As we said, cardiac arrhythmia can be treated with maternal or intra-amniotic fetal antiarrhythmic drugs. Fetal anemia due to feto-maternal hemorrhage or parvovirus B19 can be treated with intrauterine blood transfusion. Twin-to-twin transfusion syndrome can be treated with fetoscopic laser ablation. However, conservative treatment has a rule. It can be used if the etiology is unknown and there is uncertain prognosis. It includes antepartum monitoring of the fetal condition with non-stress test or biophysical profile at least weekly, in addition to fetal Doppler assessments. Corticosteroid is indicated between 24 and 34 weeks, and active intervention is required if there is fetal deterioration at a viable age or if mirror syndrome develops. New onset or worsening of non-immune Hydrops fetalis after 34 weeks is a reasonable indication for delivery. Otherwise, delivery at 37 to 38 weeks is suggested in the absence of clinical deterioration or other indication for earlier delivery. Caesarean section is reserved for obstetric indications. It is commonly performed for a deteriorating fetal condition or abnormal fetal heart rate. Regarding prognosis, non-immune Hydrops fetalis is associated with a perinatal mortality rate ranging from 50 to 98%. Poor prognostic factors include early onset, pleural effusion, and polyhydramnios before 20-week gestation, while better prognosis is associated with absence of aneuploidy and the absence of major structural abnormalities. In subsequent pregnancy, the risk of recurrence of non-immune Hydrops depends on the underlying etiology. If it was related to an anatomic variant, such as congenital heart disease, the recurrence is minimal when the anatomic variant is not identified in the subsequent pregnancy. Hydrops related to specific viral infections such as parvovirus B19 should not recur because the mother will develop immunity. However, non-immune Hydrops associated with genetic abnormality, the risk of recurrence can be high. Interventions during subsequent pregnancy include consultation with a medical geneticist, close monitoring during subsequent pregnancy, and mid-trimester ultrasound examination.